space to talk about mental health difficulties, what it entails, using simple terms to let us understand, and signposting us to where we can get appropriate help. And that's what Minds and Beyond is all about. We are going to be doing the same thing this evening. And interestingly, we are talking about functional depression. We have a guest. Our guest is an expert. She is a consultant psychiatrist. And amazingly, if you've had any form of low mood, anything at all today, just be prepared to feel better, to laugh, to feel good about yourself just by being here tonight. And that's one of the reasons why, she's a perfect guest to talk about functional depression. One thing that I remember perfectly about Dr. Ogundele is that in 2023, so she's our teacher, she's my teacher and Dr. Ogunjabi's teacher. In 2023, we were preparing for a membership exam, and randomly she just brought up a case about a middle-aged man who suddenly started having problems with their mood. And this was somebody that a lot of experts had seen and had made a diagnosis, but she was the first person to make the correct diagnosis. And you can imagine what that would feel like, because with the right diagnosis, then you can get the right treatment. And that's one of the things that we'll be covering today. But what made that case so interesting and why it's one of the cases I will never forget in my life was that we had exam. I think it was 3 days after or the following week, and that was the first question of our exam. So it was really amazing. It felt like she was in the spirit. And that's why when you're an expert, when you're a psychiatrist with a lot of experiences, you can see nuances. What people see as being normal, what people don't really recognize, you can see that because of the wealth of knowledge and experiences that you have. So welcome everybody. You're in for a great time. My name is Adebusola Adegbola. I'm a specialty doctor in child and adolescent psychiatry working with the NHS. And I'll let my co-founder introduce herself and read the citation of our guest.
Right. Good evening, everyone. My name is Omotola Ajayi or Ogunjobi, depending on what phase of life you have met me. Right. I'm sure my teacher would be like, oh, when did she turn to Ajayi? But that will be a conversation for another day. I feel very honored to be here today, and I feel extremely excited because this is a long awaited webinar. And even though a lot of people might wonder what is functional depression, it is something that is very rampant and it's something we should be able to recognize. But before I start my own personal lecture, I'm going to give honor to whom honor is due and welcome the guest. Thank you everyone for joining so far. Just give me a minute, please. Right. Please, I would like us to pay attention, our rapt attention, because this person is very special to us. Her name is Dr. Adefolakemi Ogundele. She's currently a consultant psychiatrist with the Neuropsychiatric Hospital, Aro, Abeokuta. As a fellow of the West African College of Physicians, she has over 15 years experience working with elderly people with a variety of mental health related challenges, particularly dementia and depressive disorders. She currently heads the old age unit of the hospital and is able to provide consultation, supervision, as well as treatment for a variety of elderly and adult clients. She also supervises resident doctors like myself and Busola and other clinical staff in the unit. Dr. Ogundele frequently engages in advocacy for people living with mental health illnesses, and she undertakes training in community mental health officers as well. Dr. Ogundele's clinical and research work has focused mainly on epidemiology of mental illnesses in both the hospitals and the community. Ladies and gentlemen, without further ado, I would like us to welcome this very bespoke speaker, well achieved psychiatrist, a mother, a mentor to many of us. And of course, she qualifies more than our imagination to talk about this topic in particular. So, with our wealth of experience, she's going to be sharing a lot with us. And I want us to, with rounds of applause, virtual round of applause, I want us to stay plugged in because she's going to be giving us some juice tonight. Welcome, everyone. Thank you.
Thank you very much, Dr. Gujobi and Dr. Ajayi, whichever it is.
Yeah.
Uh, a big thank you to Busola and Dr. Gujobi for inviting me for this webinar. Okay, I hope you can all hear me. I hope my voice is loud enough.
Yes,
It
we can
is,
hear
you're
you.
audible.
Okay, so good evening, everyone. I hope today has been fun. I hope today has been rewarding. Um, we are talking about functional depression in adults tonight. Tidy life, messy mind. I'm going to start with a short story. It's a personal story and one that has really, really affected me. And it brings home to me everything we're going to be talking about today. So there was this day I was meant to leave my house. I was actually supposed to go for a ward round, that's at our annex. And then somebody that I knew just called me and said she wanted to see me. So I said, okay, I still have like some 10 minutes that she could come to my house to, just see me. I didn't know what she was going to talk to me about, but I did not, I just assumed it was not something serious. So when she came, she started telling me that she had some life issues and she was telling me about the life issues. So she told me all the story. It seemed to me like it was a mental health issue. So immediately I called work and I asked if I could be excused, which I was. So I started asking all the right questions. I asked about mood. She gave me some mild mood symptoms. Occasionally, she will cry. She will feel guilty about one or two things. And then I asked questions to rule out severity. She denied. Occasionally, I had this feeling like, was she telling me the whole truth? But I was asking all the right questions and she was denying it. And this is somebody that I'm close to her. I'm closer to her husband than even she herself. So I felt that if it was serious, the husband would have really been the one to contact me because that's the person I was close to. But she denied all the symptoms. So she told me that somebody had started her on a low dose antidepressant. And I said, okay, let's see, right. But as far as I was concerned, they were just stressors, they were just life issues, and that she was going to cope with it. I told her that if somebody else had not started on the antidepressant, I would just have left her and I would have observed. So we let it be. So I would just check in with her once in a while, still the same symptoms. After about a month, and she said she was better, she had calmed down. I just cancelled her that day. And without having used the word depression, I don't think so. So after about a month or so, she called me again that she wasn't able to concentrate. So I now asked her, and that she wanted to read. Why are you reading? There's no urgent need. You're not going to school. Why is there the urgent need to read? Said she had an exam. I said, okay, I would come and see you. So I went to see her. And then we were talking. I remember that day I asked all the right questions too. And she denied all the questions. The only thing that made me a bit sensitive, a bit that threw me, that just made me careful with her. She said there was a day that her husband was very scared. Why was your husband scared? She said there was no reason. She denied anything to make me guess it could be severe. So I said, from that point on, I said, okay, I need to take you serious. I need to document. I need to bring you in. I would like to see you formally now. This has been informal enough that based on that thing that said her husband was very scared, I decided that I was going to manage as a case of depression. And so I told her that I'll see you because that day too that I saw I was quite in a hurry. So I said, I'll come to your house within 3 days, and then I'll come and see you. The second day or the third or so, but it was not yet time for our appointment. The husband had told her he was bringing her to me. And just the fact that she was going to have to see a psychiatrist formally, she took some chemicals and well, at the end of the day, she died of suicide. It was very painful to me. I kept asking myself, I kept going over our conversations. It was later, the husband now told me later, she had actually been hallucinating, but she was still going to work all this while. She was hallucinating, commanding voices. She was not sleeping at all. She had severe symptoms, which when she was talking to me, I remember asking, I can still remember particularly asking about auditory hallucinations that she denied. She said something told her. I said, what told you? She said it was my mind, you know. So she denied all the symptoms and she ended up that that was the first patient that really hit me for dying for suicide. I couldn't really, I kept going over our conversations. Did I make any mistake? Did I do anything wrong? I remember perfectly all the symptoms I asked to make sure to confirm. She denied, and she was still functional. She was going to work, she was taking care of the house, she was taking care of her family. So when I had this topic in my mind, that was just the person that came to mind. Sometimes you miss them. What is functional depression? Let's go. Can you help me scroll through? So, what is functional depression? We start by saying that appearances are often deceiving. Sometimes you see a calm face, but inside is a storm that is really brewing. So it's when you have depressive features, but the person is still able to cope with it. Keep on going. The next slide. The person is still able to cope with the symptoms. It's still functional. It still goes to work, still attends meetings, still able to cope with everyday demands. And it would seem as if the depressive features are not there. So in terms of looking at on the outside, the person is really, really coping. But on the inside, the person does really have the features of depression. Sometimes the way to look at it is to call it a laughing depression or a smiling depression. They're always smiling, they seem to be going on about life, happy, have goals, so they seem to be enjoying life, but deep within is a different story. As to in the world of mental health, do we have anything that we call high functioning depression? No. But we do have some understanding of it. And rather than call it high functioning depression, using the classification systems, what the closest to it is what we call dysthymia or what we call persistent depressive disorders. These are disorders recognized by our classification schemes. But functional depression in itself is not a diagnosis, really. But most times, because it's chronic, because the person is still able to cope with life, and so we think that the closest to it is what we used to call dysthymia, but going by DSM-5 is now persistent depressive disorder. So next slide. How did it come about? Depression in itself, depression in itself in the 20th century used to be called neurotic disorders, neurasthenic conditions, and they were usually overlooked. People tended to look at those people with those symptoms as being dramatic, as just seeking for attention. But by the 1990s, between 1960 to 1980, we had decided that it was something to take serious, and they had coined the word dysthymia, which was used to describe depressive symptoms that were mild and were ongoing for at least 2 years. In 1980, the DSM-3 classification scheme recognized it formally. And right now, by 2013, DSM-5 had changed it to persistent depressive disorder. Next slide. So gradually, it's been changing. Where we are now is that there's increased awareness. We are talking about it. We see the pain, we see the burden, we see the disability. We recognize that people that have smiling depression, high functional depression, are actually really carrying significant depression. And some of it may be severe. Up to 40% of people with high functioning depression may have severe symptoms. So we are trying to reduce the stigma and to improve support for people that are affected so that the diagnosis can be easier. How common is high functioning depression? Um, like I said, statistics on it are very difficult to get because it's not a diagnosis, it's just a concept that we talk about. And because the people that have this um, clinical condition seem to function. They rarely report it. So that makes it difficult to get the statistics on it. But what we know, according to WHO, is about 5.7% of adults globally suffer from depression. And if that be so, about 15 to 40% of that number would have the high functioning depressive type. So what we know is that most of those that have it are people that are in middle age. Middle aged women are likely to have high functioning depression more than anybody. They are the people that are likely to be coping yet have depressive features. And when they do have it, when adults have it, because it's a chronic illness, they may have the symptoms for about 5 years. When teenagers and young adults have it, they may last for about 2 years before some form of resolution. And because we know that people with depression really have, there's a treatment gap that is significant in their treatment. They really seek treatment, only just depending on the client, just about 60 to people with depression receive orthodox treatments. For people with high functioning depression, lesser proportions receive treatment. A lot of them do not receive treatment. So they kind of they suffer in silence, really. Um,
Sorry to interrupt you. We're not able to see your full face, ma.
okay, sorry.
Okay, thank
It's
you.
how I keep changing my phone. Okay,
Okay,
let me make it.
yeah.
No. Is it better now?
Yes, yes, it's perfect. And I would be on the slides.
Slide, please. Next slide. Okay, so we know who Robin Williams is. In his lifetime, he was a comedian. He entertained a lot of people. I remember watching some of his films. He always seemed to be happy. Well, most of his films, usually, he played the happy role. He was the happy man. He made people laugh. Everything was always fun with him. He reduced people's stresses. So it was quite surprising when we heard that Robin Williams had died of suicide. That showed that not everything seemed to be well with him. Even though he was the one that was making people happy, he would show that he himself was not too happy. But after his passing, more news came to be about the fact that he had condition. So it's tidy life. Everything about him seemed to be tidy. He had a good family, his wife was supportive, and yet he died by suicide. But his mind was quite messy. So why is it messy? Why do we say it's messy? Because there's persistent sadness. They feel the sadness is pervasive for them. Whatever they're going through in their mind, they know that they are not happy. And the sadness is into all things. It doesn't really shift. Whatever they are doing is persistent, it's pervasive, they know. And there's this loss of interest too. Most times the sad feeling is um, like I said, is there, but it's usually mild. There are cognitive symptoms. They have problems with concentration. They may have some memory problems, but it's not sufficient enough to interfere with their daily life. What expressive symptoms, really? They can have fatigue. They can have some uh, and anxiety symptoms, which are to they seem to be coping with it. But more importantly, they can have suicidal ideation. They can be suicidal thoughts, can be suicidal behavior, which are often not communicated. Um, um, why is it the hidden nature of it? It's because there's lack of overt sadness. Like I said, it's not so bad. It's there, but they're able to cope with it. Then to carry responsibility They know their responsibilities, excuse me, and they're able to cope with it. They carry on with their day-to-day activities. They go to work, they still carry the files, do their duty. So whatever the presentation they have, it doesn't interfere with their work, it doesn't really interfere with their relationships, particularly work relationships, but interpersonal relationships with family, it may interfere, especially if the person has anxiety or irritability. And then they are to masking their emotions, give they give more, they seem to be different to pain. You really get what they're going through just by looking at them. Listening to them. They use a lot of comedy because it's tonic in nature. It's been there as well. Everything is used to. We are sometimes she's quiet, sometimes she's social withdrawn. We just said that this is a new group evolving, and then we just seem to accept it like that. And then people know how to keep their pain private. There are people who, by reason of their personality, they know how to keep quiet their pain. And that's why main healing for them. So we talk about their tidy lives. And like I said, they have established routines because their routines are very established. It's something that is so established, it's so rigid that it's for so you
Ma,
can see that
ma, the network
after I
is the network is breaking up, and we're finding it difficult to hear you, ma.
the network seems good.
Eh,
Okay, is it better now?
no, ma.
Oh, okay. Let me see if I can have a change of. Let me see if I can find a Wi-Fi to it.
Okay, thank you.
And look, I've added a Wi-Fi to it.
It's
Is it
clearer.
better?
Yes, thank you. Thank you so much.
Okay. Okay. Um, I talked about why it is hidden, why we may not see it, why they may not show it. And we said because their routines are established. You know that you wake up at 6, you're supposed to join the bus at 7. You have this established routine that you just seem to follow without putting too much thought into it. And you are not you don't really have to do too many changes from day to day. So that's why one of the reasons why they're able to maintain their functionality. And then because of they have maintained responsibilities, they carry on so many people's issues, they carry on so many roles, they are into too many things. So they just seem to be interested in maintaining those roles and responsibilities. So they don't have time to dwell on whatever they're going through. And then they are used to masking their emotions. They have the skills to mask their emotions. Not everybody has the skill to engage in humor. So they're always using humor, sarcasm, to cover their pain, like Robin Williams too, because he was so used to comedy, it was so natural with him to joke around. So for a long time, most people didn't know that he had a depressive illness, except for his family members. And then because of the chronicity, because it's been there for so long. Everybody just feels that, oh, this is a new you. This is a new Folake. Oh, she's growing up. Oh, okay, she has become a teenager. That's why. And then it's been so long. So this is the new adolescent. It's been there for. So it was when he was 17 that it started. So it's an adolescent thing. This is the new person now. So we can just accept it as it is. And because it is also gradually nonsense, we don't seem to notice the sudden change. There's no sudden change. So because it's a gradual thing, we just kind of accept it that this person is growing. Even the person accepts it that, oh, this thing is just something that is there and it's new me. I can cope with it. And then there are people that know how to internalize suffering. So they know how to package that suffering into a space where they are not alone. They don't get to it. They can manage with whatever burden is in their hearts. So in their mind, it's not an issue. So they know how to internalize pain. They don't talk about it. They can leave it until when they're alone to dwell on it. Next slide, please. I think you're a bit too fast. So we say that why is it a tidy life? Like I said, okay, established routines. They know how to minimize symptoms, or they may misattribute it to something else. So I'm having fatigue. I might feel that, oh, maybe age is catching up on me, or I'm having fatigue. I might just say, oh, because I'm not sleeping well, maybe because the work seems to be too much. I might be irritable, and I might just say, oh, maybe because somebody around me is always the one annoying me, or maybe it's because of this new treatment I just started for my hypertension. Maybe that's just why I'm irritable. So they can minimalize symptoms, or they may attribute it to different things because of physical ailments, because of fear of stigma. Like the person I talked about, the main issue that I found that was wrong with her is she was afraid of stigma and the burden of taking treatment for mental health issues. And then social expectations, because we know that there's a lot of social expectations. I'm a medical doctor, I'm a psychiatrist. How can I tell anybody that I'm suffering from depression? So because of our social expectations, we don't tend to talk about it. We don't tend to let it show. We kind of hide it. And talking about next, like social expectations, we would remember Churchill. Churchill is well known, but at the same time, Churchill, as a British Prime Minister, had depression. He suffered greatly from depression, but he was still able to cope as a Prime Minister. He was still able to do his work and cope. And this is his quote that shows that when you talk about social expectations, people just expect you to go through it. He says, when you are going through hell, keep going. That's his own quote to all the things that he went. So he just felt, oh, okay, you are going through it, just keep going through the hell. It really does not matter. Just do the work and know that the hell that you are in is for you to dwell when you are alone. Just keep going, So it shows that social expectations puts a lot on us. Why we're still talking about why it is hidden. Even for families and even doctors, we have challenges with identification and also support. Even when the clients, the patients, they go see healthcare workers, because they are not complaining about depression, we don't see it. We tend to put it under so many other things. So except the patient is complaining, most patients with high functioning depression, when they do see their healthcare provider, they are likely to be labeled as being unhappy rather than as having sad mood. We change the terminology. So even when the patient does complain, the doctor tends to see the patient as not being happy momentarily rather than having sad mood, which will go for a depressive symptoms. But it said that if you do see mental health professionals, they tend to pick it early. They tend to recognize it well. And then family misinterpretation too, particularly when the person is having symptoms. So we tend to misinterpret. We can say, oh, this person has become lazy. You can say this person is just does not love me anymore. She's always irritable. we may not diagnose well. So in terms of the family, they put other names to what they see, the few things that they see. And then because the person also withdraws from people and tends to self-medicate, it may be hidden from families and also professionals. And then because we don't tend to have empathetic conversations, most times in our clinics, we run routine clinics. You are usually, even when I say, how are you? I expect I'm good. That's the usual response. Even we ourselves, when people say, how are you? The first thing you would likely to say is, I'm good. You're likely to give a positive response because that's the way we are conditioned, not necessarily talking about our mood. We know it's asking, and those of us that are asking, we are not asking for deep questions anyway. And the people that usually respond, they are not really responding to give you the full picture. Rarely would you find people who would ask you, how are you? And you will know that this is deep and that the person is willing to listen to you. We are not most times willing to listen. We are just asking and on the move almost immediately because of there's no lack of empathetic conversations usually in most clinical settings. It gets mixed too. High functioning depression gets mixed. What are the risk factors? Family history. Um, it's common within families. It's common to people who have experienced losses in any form, financial loss, loss of social roles, particularly in adults and older adults. Not everything is loss of a loved one, but of course, bereavement, loss of um, social roles, financial roles, um, changes in living situation, whatever loss, it can be risk factors. And then chronic illnesses too can be a risk factor, and medication side effects can be a risk factor. Social isolation and loneliness is also a risk factor. And chronic stress, people that experience stress, especially that are chronic, they will just tend to feel that they are used to it and ignore the depressive symptoms that they are used to. Caregiving burden, particularly in people that are taking care of older adults that have a lot of disability. And then personality disorders, people that have pessimistic personality, perfectionism, those people that have those traits and they are high, they tend to have high functioning depression. What are the complications? Of course, reduce quality of life. Is the person enjoying life? They are going through life, but are they really, really enjoying their life? Can they have fun? Can they plan holidays for themselves? Can they plan to take time off to just relax? Can they really even relax? Really, no. And so they do all this work. They may get accolades at work, but they don't really enjoy life. So they're going through life without enjoying life. The quality of life, most of the time, they admit that is reduced. They're just doing the work. There's really no job satisfaction even in the work. There's really no sense of accomplishment in whatever they are doing. So they reduce quality of life. And then high functioning depression too can cause conflicts, conflicts within families, relationship problems, because this person is depressed, is most likely maybe socially withdrawn. He cannot enjoy relationships, cannot enjoy conversations with people. He would make conversations, but just on the surface level, nothing deep, nothing empathetic, not involving herself or himself with the other person. So family conflicts and relationship problems. And then they may have difficulty holding jobs. Remember, we said they may have problems with concentration, they may have problems with job satisfaction, so they may keep changing jobs, and they may not do well also in um, any work area, including school. They may abuse drugs and alcohol, like for self-medication. So they may go into drugs and alcohol. Um, and that can be very dangerous because it might take time for them to even know that they are actually abusing drugs. They might just create a pattern where they are using the drugs and alcohol to fill in the gaps, to fill in um, to fill in time for them so that they don't feel the sadness too much. And then um, they may have they have increased morbidity. Chronic pain and physical illness is also one of the side effects. And let's not forget suicide. Suicidal behavior is very high. It's one of the major risk factors, one of the major complications of high functioning depression. So the person is smiling today, and everybody is shocked that this person is attempting suicide tomorrow. it's because the person has been covering up for so long. And we really cannot understand where this is coming from. We're just baffled. Why is it coming? But then, most times when we do, hopefully, if it's not too late, if you were to review a retrospective review of your relationship with the person, you might actually detect changes, you might detect some of these signs. Hopefully, it won't be too late. So, suicidal behavior is one of the major risk factors, is one of the reasons why people are pushing for increased awareness for high functioning depression because of the suicidal risk, which is very high. I tried to get data on how much risk it covers, high functioning depression puts as a risk factor for depression, but I really could not get consistent findings, so I just left it out. But everybody says that when you have high functioning depression, you must be careful of the person attempting or committing suicide. How do you manage? This is more personalized than just general. One, you prioritize yourself. That's assuming you're the one that is going through high functioning depression. Prioritize your self care. Start thinking about yourself more and plan how you can even distract yourself from the symptoms. Be realistic with your plans. You must start small. You don't want to change your life suddenly all over in one day. So you must start small and you must be realistic about the things that you're doing, and you must personalize it. It must be things that you would enjoy. It must be things that you can do for yourself. And then, as much as possible, general health living tips. Exercise regularly improves mood. Studies have shown that. Also, manage your sleep schedule. Make sure you're sleeping at a consistent time. And then limit alcohol and drugs. Limit coffee if you have to. Um, and then practice a lot of relaxation techniques, mindfulness, yoga, meditation, anything that makes you feel better about yourself and relaxes you. Give deep relaxation not only to your muscles but also to your mental reasoning abilities. And then, as much as possible, make sure you seek professional help. This is very important, especially for people who are in sub-Saharan Africa, where we tend to spiritualize a lot of the issues that we go through, and we tend to, rather than seek professional help, most of us would rather seek spiritual help and attribute it to possibly anybody that is attacking you spiritually. So it's important to seek professional help. And like I said, in where I live presently, sub-Saharan Africa, um, we stigmatize people that go for professional help. So it's important. And we tend to think that going for professional help means that you're going to give you injection or you're going to take tablets. Not necessarily so. We are at a stage where people can participate actively in their management, and you can work with your mental health professionals to have a personalized treatment design that will suit you. You have a voice, so you can use it to at least be part of your treatment. So, what are the treatment options that are usually used for high functioning depression? You have psychotherapy, another psychotherapy, depending on what is found, they will offer you so many types of therapy. But the common ones are the cognitive behavioral therapy and the interpersonal therapy. They use that a lot for high functioning depression. And then in terms of medication, um, depending, not everything it's not rigid, but the first line is usually the SSRIs that are offered. And so those are the treatment options. So essentially, talking about high functioning depression, what we want to push is to understand that there's significant burden, there's significant suffering with high functioning depression, and increased awareness is what we should do. We should discuss about it. We should encourage people that we suspect will be going through it to speak up and to seek help. Thank you very much. That brings us to the end of the um, discussion.
Amazing. Thank you. Thank you so much. Again, I would reiterate that there is no better person to do justice to this topic You started with a life experience of someone that you knew, and even as a very well experienced psychiatrist, you were vulnerable enough to say that you missed that beat, and of course, it made you more aware and more on the lookout when you saw people with similar symptoms. So thank you so much. I'm sure a lot of people would be able to resonate with some of those things that you have said. And so would like to open up the opportunities for questions and answers. Does anybody have any question or answer? Any questions rather?
Please feel free to type your question in the chat box or raise your hand. And while we're doing that, I think it's just so interesting about the stories you shared. There was one that happened in 2022. I don't know how many of us are familiar with Twitch. Stephen Boss, who was the DJ for Ellen DeGeneres. And these are people who kind of have like lifestyle activity. He was a DJ and he was a professional dancer. And these are people who kind of have this lifestyle activity that we say promotes mental wellness, and it still suddenly died by suicide. Nobody could tell what was going on. The co-workers, the wife, at least according to what we know from the media, which is not always accurate. So it just goes to show how this can happen to a lot of people. And it was really interesting when you were saying that we don't have empathetic conversation in the clinic, and how as professionals we can also be dismissive, to be fair. We say this one depression. You are depressed as you are like this. So it just like that we are able to open our eyes to really see that it's not one size fits all, and have a personal conversation. One of the things that is always helpful is silence, social withdrawal. That social withdrawal, anhedonia, social isolation can really give a pointer of what is going on. Starting conversation with pre-morbid activities. What are the things that you tend to do before all of this started can be quite helpful. I have one question though. How do we differentiate functional depression from major depressive disorder with atypical features?
Okay, with atypical, usually for major depressive disorder, um, the time to presentation is usually shorter. Most times, people with high functioning depression, they have a more chronic history, and they are less likely to talk about it. Because high functioning depression too, they may have atypical features like oversleeping, overeating, and things like that. But the main difference is the duration, which is usually shorter. And then people with major depressive disorder are more likely to talk about it. They are not likely to be functioning. You are likely to see it. And that makes the difference. For clinicians, like I said, when you see people with major depressive disorder, it's very easy for you to put it to name and say, oh, this person is experiencing sad mood for 6 months or so. But when you do see people who have high functioning depression, you are just likely to say, okay, she has problems with her husband, she's not happy. You are likely to use the word happy or not happy or unhappy. Rather, because the symptoms of major depressive disorder are usually more severe, the patient is likely to talk about the symptoms, the depressive symptoms, psychological symptoms, cognitive symptoms more rather than the high functioning depression. They still, both of them have depression. It's just that one is still going about work, one is still smiling to people. Whereas most of the patients we've made diagnosis, I have made diagnosis of depression. From their faces, from their affect, you know that this person is depressed. But high functioning depression, you can't get it from even their affect because they are smiling, you are distant, they are engaging you. Both of you are laughing, you are in your clinic, and the people outside can probably hear you giggling and everything like that. But patients with major depressive disorder, you would almost look at them and almost want to weep with them, empathy. But with high functioning depression, not so much. So I think that's what differentiates. And what we should go out for is just to go for the symptoms. So if by the time you are able to establish low mood, by the time you are able to establish chronicity and two other symptoms, I think that's DSM-5 criteria for persistent depressive disorder. So by the time you're able to establish two other symptoms, low mood and chronicity for at least 2 years, you can go ahead and make a diagnosis of high functioning depression. Let me say though, concerning Robin Williams, at autopsy, um, they did find that he had advanced Lewy body dementia at autopsy, and that was what was able to help the wife to cope, because even the wife never suspected that it was that suicidal, you know. So it was at autopsy that they found that he had extensive Lewy body dementia, which and he used to have some episodes of confusion too while he was around. He had the cognitive symptoms seems to be more before his death, but because they had known that he was having, because even with high functioning depression, you can have episodes of major depression.
Yeah.
You can have episodes of major depression. So they just felt that okay, maybe the depression was coming, but they didn't really pick that Lewy body. And it was a fact that helped the wife to have some form of closure as much as it could be. So that's why we said physical illness is a risk factor for high functioning depression. But how bad the depression was, the wife did not know. And she thought it was a guilt point for her for a long time, according to what I read on social media.
Mm.
I think that's a very, very useful tidbit to add, because I was going to say that maybe possible that, they also mask to their spouses, their friends, people close to them, and, even those who are very close to them are unable to say that I think something is going on and you need help. And so,
Mm, yes, they think so. The few ones I have had to see, the relatives did not agree with the diagnosis. In fact, I saw a woman who was very suicidal. She had attempted suicide some few times. The husband denied it. He said she was just being dramatic. And they didn't, he was supportive of her. He was very supportive of her. But he still denied it. Funny enough, he's a medical person too, but he didn't agree. And she was suicidal. She was very suicidal. Well, she didn't tell the husband, but she told me. I saw her informally. She
mm,
had attempted suicide. She had used knife. She had used different methods. Just didn't die. But the husband just said, "Oh, just gave different excuses for it." And
mm,
of course, within the next 2 days that I saw her, she was dancing and jumping all around.
oh, amazing. Amazing. I think that's really great. It is quite true that, as medical professionals and even as a psychiatrist, especially when we are seeing it in people that we know closely, it can be quite difficult for us to pick it up. And sometimes we are just in denial of any possible diagnosis or anything going on. And it really take, somebody looking in from the outside to really be objective and say, you said this, you've noticed this, all of this is going on. I think this is what could be going wrong here. So it's just for all of us to have a higher index of suspicion, really, and be able to know that people present in different ways to be able to pick it up. And it is alarming the percentage of people who have seen mental health professionals before actually having a completed suicide. I think it's about 40% if I'm thinking at the top of my head. And if all that we are able to achieve from today's webinar is to even bring that number down, because a lot of people here are medical professionals, mental health professionals. By having that high level of suspicion, I think today's webinar, would be worth it.
Yeah, and I suppose just like Dr. Ogundele stated, the first line of management is not necessarily medications or even having like major psychological support. It could just be everyday habits. And if you've attended our webinars for a while now, you will know that everyday habits, we are very big on everyday habits like exercises, relaxation techniques. If you watch our YouTube videos, you would see that We have even taught, Busola has taught relaxation techniques on this one of these webinars. So it's also about the consistent little things that we do for ourselves. It's so easy to give out to other people, especially I think that this, because most of the examples that you gave based on the interactions that you've had are women. So women tend to give out a lot of their emotions. They make sure every other person is fine while they neglect themselves. So just those little things that, just like Dr. Gundele said, that'll make you happy. Even if it's getting your nails done. I mean, it sounds very basic and routine, but if that's what gives you joy, I've met people that would say, putting on makeup makes me happy. Yeah, go for it, do it. And
Mhm.
it's just for you. You deserve to have moments where you pamper yourself. You can go for a walk, read a book, listen to music, dance when no one is in the house. Those things will release endorphins. You would feel happy because honestly, life is too short to be depressed. Like I feel like we were still having a conversation at a conference that I attended today, and we're like, honestly, depression is really dark, and you don't want to spend maybe 5 months, 6 months, 2 years of your life feeling so low. So for as many people as can try, I know that obviously it's out of control for a lot of people, but just try to do those daily things consistently, things that will fill you up, not because we keep pouring out. So things that would fill you up. Yes, I have learned a lot from today's webinar, like a whole lot. But I just had a question for you, Ma. I know that you've helped us to differentiate between major depression and functional depression very clearly. And I don't think we have any doubt about that. But I just wanted to know, we had a webinar on burnout. Ma, can you hear me?
Yes, it's going on and off though.
Okay. Busola, can you hear me?
I can hear you. There's a bit of a background noise, but we can hear what you're saying.
Okay, the background noise is not from my end. Okay, right. So we had a webinar on burnout. It was also a seasoned psychiatrist that spoke to us about it, and many people on this call were also there. I just wanted to know, is there a way to also differentiate burnout and functional depression, or is there an overlap for maybe some people? How do we tackle that as well?
For burnout, really, it's just the fatigue and the struggle to keep going on. Whereas for high functioning depression, you do have depressive features. You have low mood. It's not just the cognitive features, it's not just psychological. You have the mood, the changes, the sleep, biological features are also there. So you know the changes. And but for burnout, it's just feeling tired, feeling worked up, feeling stressed. Those are usually the features that are there. So that's the main difference um, with between burnout and high functioning depression. High functioning depression is still depression. It still
Absolutely.
goes with everything depression. But some people with high functioning depression though may present as burnout because their complaints may be only with that aspect of life, maybe
That they
work
have to keep up
or
with.
Yeah,
that they'll complain about. But for high functioning depression will be usually um, everything. That's why we say it's pervasive mood change. So
Mm.
that's the difference. But
okay,
if you do get somebody saying burnout, you should ideally um, review for depression
Yes.
true.
and anxiety, the common mental disturbance.
Mm.
Absolutely. Okay.
Yeah, I think that's very helpful. I just want to chip in very lastly that sometimes people experience high functioning depression when it seemingly looks like something good is happening in their life.
Mhm.
They have changes. Maybe there's a new child, there's a new job, relocation, or whatever. And it feels like, how dare you speak up that you are depressed when, all of these things are going on for you? What, how dare you complain? How dare you open your mouth? God has been good to you. How dare you now say that, you're sad, you're depressed, or something is going on with you? So it just go back to that our background and the courage to speak up, the courage to seek help. irrespective of what's going on, irrespective of all of the good things, being able to recognize that even good things can cause changes, mental health difficulties and mental health changes, and having that courage to really seek help, irrespective of what phase you are, what is going on, what feels like, I'm doing something that is a dream to other people. And how dare me say, oh, I'm depressed or I'm sad. Please, let's have the courage to seek help.
Yeah. Right. Busala, did you want to
Thank
take
you,
the
Busala.
announcement? Thank you. Thank you so much, Ma. That was very
Thank
engaging.
you too.
Yeah. I think, first of all, I want to say thank you to Dr. Ogundele for joining us this evening and really taking our time to have this robust conversation with us, opening our eyes, helping us to see that this thing is present and it is quite serious. And it's not something that we can sweep under the carpet, and giving us that real life example that people have died from this. So it's something that we need to be aware of so that we can help ourselves and we can help others. We have another webinar coming up next month, December. We are going to be talking about mental resilience. So all of the things that has happened in 2025, we are going to be dishing it out, how we've been able to, keep ourselves going, and all the things that we need to start 2026 on a good note. We have an amazing speaker coming. She's a great speaker, another female speaker. So definitely be on the lookout to register and join us. We know that this is a safe space. We are usually, very small. We have honest conversation and we learn at the end of the day. So we would be looking forward to having you guys join us next month. And please help us complete the feedback form. If you have anything, any complaints, anything that we can work on to feel better, to do better, please let us know. And if you have any topic ideas as well that you want us to address in 2026, we would be open to, having the conversation. And if you're on our email list, and you have any question, feel free to send us an email and we would be happy to respond and give you information about how to seek the right support.
Thank you. Thank you, everyone. We're right on time as always.
Good night.
Good night. Good night, Ma. Thank you so much, everybody. Nice to have everyone. Thank you to Atayo, Leo, Fumi, Adedayo. Okay. Oh, I didn't see. Okay, Dr. Dumbaku and the many other people that have joined. Thank you so much. Such a pleasure. Abimbola.
And all
Thank
the
you.
regulars.
Yeah,
Thank you
Desire.
very
Yeah,
much.
we
Yes,
have our
Desire.
we have our regulars. Yes. Thank
Thank you
you.
for constantly joining. It's always a pleasure to have you all.
Yes, Dr. Ladisu. Thank